My name is Yervant Ichkhanian, one of the authors of the manuscript titled Appendicitis Post-Endoscopic Full-Thickness Resection of Polyps Involving the Appendiceal Orifice, a multicenter international experience. On behalf of the authors, I would like to thank the editors of Endoscopy for giving us this opportunity to present the outcomes of our study. Endoscopic removal of polyps involving the appendiceal orifice is challenging. Traditionally, these polyps are managed surgically with either right hemicolectomy or radical appendectomy. Endoscopic techniques such as EMR or EST have been utilized for resection of such difficult lesions. However, they are often technically challenging and associated with higher risk of incomplete resection or higher risk of adverse events. Endoscopic full-thickness resection, EFTR, using the FTRD, which is the full-thickness resection device, have been employed for colorectal lesions that are difficult to resect, including these lesions located in the appendiceal orifice. However, post-EFTR appendicitis remains a major concern, with different studies reporting inconsistent results of incidence rate ranging from 0% to 50% of appendicitis. In this study, we aim to perform a comprehensive analysis on the specific use of FTRD and try to identify factors that are associated with occurrence of the appendicitis. This is a multicenter retrospective study on endoscopic full-thickness resection using FTRD of lesions involving the appendiceal orifice in the cecum. Consecutive patients who underwent technically successful or failed EFTRD using FTRD for appendiceal lesion during the time period between September 2016 and August 2020 were included. A total of 18 tertiary care centers were involved in the study. 12 were in the United States, 1 in Canada, 5 in Europe. A total of 66 patients underwent resection of colonic lesions involving the appendiceal orifice. They had a mean size of 14.5 millimeters, and 61% of these lesions had deep extension into the appendiceal lumen. Technical success, which was defined as achieving an en-bloc resection, was found to be in 59 out of the 66 cases, giving a rate of 89%. Reasons for technical failure included failure to pull the lesion into the FTRD cap due to the lesion characteristic, and this was found in 5 cases. Therefore, the clip was not deployed and the EFTR procedure was halted. All these 5 patients were eventually referred for surgical resection. In 2 cases, the technical failure was attributed to failure to achieve an en-bloc resection, and in these 2 cases, they were managed during the same session with cold forceps or hot snare resection. Clinical success, which was defined as having a technical success without the need of further surgical intervention, was achieved in 53 out of the 66 cases, giving a rate of 80%. Out of the 56 lesions that they were found to be neoplastic on post-resection pathology, R0 margin resection, which was defined as having negative lateral and deep margins on histologic evaluation, was achieved in 52 out of the 56 of these cases, giving a rate of 93%. Histologic full-thickness resection, which was defined as having resection including the muscularis propria with or without the serosa, was achieved in 91% of the cases. Out of the 58 patients of whom EFTR was completed and had no prior history of appendectomy, appendicitis was reported in 10 or 17% of the cases, with 6 or 60% requiring surgical appendectomies. Comparing the patients who were diagnosed with appendicitis versus the patients who were not, male sex and failure to achieve histologic FTR were significantly associated with appendicitis occurrence post-EFTR. Pre-procedure prophylactic antibiotics were given in 60 or 91% of the patients, and both pre- and post-procedure prophylactic antibiotics was given in 45 or 68% of the cases, and they were continued for a median of 5 days. Antibiotic usage was not significantly different among patients diagnosed with or not diagnosed with appendicitis. Follow-up colonoscopy was completed in 41 cases, with evidence of recurrence in 5 or 12.2%. The following figure shows a FTRD procedure for managing an appendiceal orifice lesion. In Figure A, we can see the lesion pre-resection, and in Figure B, we can see the FDRD marking probe is being used to mark the edges of the polyp using soft coagulation current. In C, we can see the FDRD grasper is being used, that is inserted through the working channel, to pull the lesion into the transparent cap, which is followed by the deployment of over-the-scope clip, and eventually resecting the lesion by tightening the snare that is located at the tip of the cap using the endocut Q current. In D, we can see an endoscopic view of the deployed over-the-scope clip post-resection, and F shows the lesion as being prepared for the histologic evaluation. In F, we can see an evidence that is found on CT post-EFTR indicating appendicitis, which led to an laparoscopic appendectomy, which is seen in G. Lastly, H shows a resected appendix with the previously deployed over-the-scope clip. In conclusion, taking into account the potential appendicitis risk, endoscopic resection of appendiceal lesion with the FDRD is a promising modality for managing patients who favor endoscopic resection or are considered high risk for surgical management. Despite the lack of evidence for the benefits of prophylactic antibiotics, their use is still recommended, as well as proper communication with the patient about the potential risk following the EFTR. Further studies are required to prospectively evaluate the feasibility and safety of FDRD for the management of such lesions, as well as identifying the subgroup of patients who might benefit from EFTR as opposed to traditional surgical resection.